You're listening to Psych with Mike. If you enjoy the show, then help us out. Go to Apple Podcasts and rate us and leave us a comment. That is so beneficial for the show, and we would really, really appreciate it. But in addition to that, you can follow us on Twitter at Psych with Mike. You can like the Facebook page at Psych with Mike. And now you can even catch us on TikTok at Psych with Mike. So please subscribe to all of those different ways to stay connected to the show. And as always, if it's Friday, it's Psych with Mike. Welcome into the Psych with Mike library. I'm Dr. Michael Mahan, and I'm here on a wintry day.
I hate wintry days.
With Mr. Brett Newcomb.
Yes. I want to go south. I want to go somewhere where it's warm and the sun shines every day.
Yeah.
Is there a place like that?
Is there it's called Turks and Caicos.
No balm in Gilead in search of El Dorado?
Called Turks and Caicos.
Yeah.
Which is actually an island nation that you introduced me to, and is now my absolute favorite place on the entire face of the planet.
Yeah. It's a beautiful place.
Yeah. We go to Mexico more, but I like Turks and Caicos better. It's a little bit more expensive.
Well,
you know this. You've done all of that, so don't act like you don't know.
I'm in a constant search. I have a quest for someplace warm.
Mm-hmm. Well, that would be my recommendation, although you're going to go some other places, because you're going to stay.
Always. I'm going to try different places.
You're going to stay in the boundaries of the U.S.
For now.
Yeah. Yeah, I don't think I would be comfortable leaving the U.S. quite yet.
I'm personally not comfortable flying right now. Yeah. So we're going to go somewhere where we're going to go in our car, and we're going to stay in state parks and camps so that we avoid contact with people as much as possible.
Mm-hmm. That is the smart thing to do. You know, for as much as we travel to the beach and everything, my son, whom you know, who's always been fascinated by animals, has always wanted to go to Yosemite and Yellowstone.
Beautiful places.
And we've never done that. And so we were talking about this year doing that because, we don't know when travel is going to be sanctioned as safe. Obviously, you can travel, but I don't know when we will be ready to travel. And so I'm really honestly thinking about doing that this year.
I was having a conversation about exactly that a couple of days ago with someone, and we were talking about camping in Yellowstone, and they have, in the campsites, they have metal bear lockers to put your food in, lock it up. So, and they warn you, and when there's a bear alert. I remember camping in Great Smoky Mountains in Tennessee, and when we pulled into the park, the rangers said, there's a bear alert, so don't take anything out of your car to eat or drink unless you're actually consuming it in that moment, and then when you finish, put it back in the car. Don't put it in your tent, don't put it at your campsite, leave it locked in your car. And if the bears come to your car, stay out of the way.
Let them destroy whatever they're going to destroy.
It's dangerous,
Yeah.
And we saw half a dozen bears. So
probably good advice.
Yeah. Well, it was good advice, but it's not any advice. I've camped a lot of places a lot of times. Never been told that before.
And it's not...
They said even toothpaste. Leave your toothpaste in the car.
Really?
Nothing. Don't wear aftershave or deodorant or smelly stuff. Cologne.
I wonder how many people in America, though, hear that message and it falls on deaf ears because they think, I'm an American. We do what we want. It's fine. Bears can't stop me from being an American.
There are those who have that response to the whole question of wearing a mask.
Yeah.
Is that where you wanted to go with that?
Not really.
Oh, okay.
I just was thinking those people end up being bear fodder.
I certainly hope so.
Yeah. So we're going to talk about something you had mentioned to me that you were, I don't know if concern's the right word, but you were aware that we've drifted away from a purely clinical focus, which I agree we have, and I do believe that should be our focus. And so I sent you this article because I've told you this before, and I don't know if you wear it as a badge of honor or not, but of all the people that I have known in my clinical experience, you have dealt with more and dealt more effectively with people who have borderline personality disorder than anybody else that I know.
Borderline personality disorder is an Axis 2 diagnosis, personality disorder, and there's a cluster of personality disorders. It is one in a cluster. And I don't remember that I ever personally diagnosed anyone with that label. It's usually reserved for people with more higher clinical degrees than I possess, like a physician, a psychiatrist, even a licensed psychologist such as yourself. Generally, when insurance companies look for payment, which is the primary reason for coming up with a diagnosis, they take the diagnosis provided by the most high-ranking clinical authority. Mm-hmm. So I've dealt with a lot of people that came to me with that label, but I don't know that I ever applied it to anybody.
Mm-hmm. Well, but if they came with the label, then somebody else. And just for full disclosure, I am licensed as a professional counselor. I have a degree in clinical psychology, but I don't want people to get confused.
That you're a clinical, right? Yeah. Okay.
But you believe in borderline personality disorder.
Oh, absolutely.
Yeah. And so talk a little bit about what are the dimensions of that are clinically significant.
Chronic feelings of emptiness, emotional instability in their relationships and just in their day-to-day life. They get flooded a lot, and it's a severe pendulum swing. Mm-hmm. You know, from good to bad. You know, one of the early explanations of what was going on was called splitting, mm-hmm. and you'd split between good self and bad self. And the theory was that when you were a child, before the age of 3 or 4, before you started developing the standard defense mechanisms that we all study and learn about, that you had an object, in this case the mother, who was emotionally available mm-hmm. and supportive, or emotionally not available and supportive, and that your coping strategy for dealing with that was splitting. Mm-hmm. And so when good mom was there, who would love you and smile at you and coo at you, good self would come and get all the sun rays. And when bad mom was there, who wouldn't embrace you, who talked angrily, who radiated a coldness and a hostility or an emptiness, then bad self would come and be present for that. Mm-hmm. And then you grow and evolve later when you become more sophisticated. Then you layer on the defense mechanisms that most people develop as they evolve and grow, but it's over a cracked foundation. Mm-hmm. And so that when life presents stress in levels that you can't handle, then that cracked foundation will split again and you'll go back to good self, bad self. Mm-hmm. And so they are constantly experiencing a dance of internal identity fracture, mm-hmm. where they go from being composed and competent, and they see themselves as being able to function and do good things in pursuit of their happy life, to being not acceptable and bad, and they're angry and they lash out and they can be violent in their relationships. It's really chaotic.
So in your experience, does a person who has borderline personality disorder, do they recognize those distinctions?
No, and they're accused of it constantly, and they're like, what, me?
Yeah.
You know, like the Mad Magazine thing.
So then they become defensive when they are confronted with it?
They tend to fall into impulsive behaviors in some category, like impulsive spending or impulsive mm-hmm. sexual acting out or substance abuse, reckless driving, those kind of things, mm-hmm. As a way to burn off the energy that they can't process.
So that sounds very much to me like manic behavior. Would that be?
It can be.
Okay.
Yeah.
But the motivation, the drive for that would be different than for manic behavior, but it might look like that.
Yes.
Okay. Yeah. So in my experience, I will readily admit that I don't feel clinically good about treating people with borderline personality disorder. The few cases where I know that I've run into it, the way that I experience these individuals is incredibly seductive.
Oh yeah.
And then when you fall into the trap of the seduction, mm-hmm. you're the best thing since sliced bread until you're not, and
Right.
then when you're not, they're vicious in the way that they just rip you apart.
Yeah, there's a great book about that written by a psychiatrist here in St. Louis, Andrew Kreitzman, called "I Hate You, Don't Leave Me." Gerald Kreitzman. I'm hesitating. I knew I had Andrew, but was wrong. Gerald Kreitzman. "I Hate You, Don't Leave Me." Because that exact, and when you say seduction, sometimes that's a sexualized seduction,
Right?
But most of the time it's not.
Right.
It doesn't have anything to do with
I've
sex.
experienced it both ways. I mean,
Yeah.
like they will say, "Oh, you're the smartest person we've
Right,
ever met.
right.
You've helped us so much," and then all of a sudden you do something, and that flip happens, and they go to bad. What did you call it?
Bad self.
Bad self.
Yeah.
And when that change happens, they're just
Or they move
vicious.
you from the idealized person to the bad person.
Yeah.
And so then they can dump their anger on you, and that lashing out anger is
Right.
Yeah.
And you don't see it coming. There's a line in Meatloaf, "Bad Out of Hell." I never see the sudden turn until it's way too late.
Right.
And then I could go on with it, but I won't.
I'm sure you could.
And that's how I feel about working with those individuals, is that I never see the sudden turn until it's way too late, until I've been eviscerated.
But people
and
that
then,
live and work with them experience what you're describing, and they never know what they're dealing with. Is the dog going to, purr? Is the cat going to purr, or is it going to scratch me and claw me? They don't know. And so, and children in those households are really have a double whammy, because children innately think it's my fault. There's something I'm doing wrong. If Mom is mad like this and unpredictable or violent, or Dad is, then it must be because of something I did or didn't do. So they get really crazy trying to figure that crap out and figure, how am I going to be safe and get warm, loving Mom or Dad to come back?
Yeah.
And it's got to be me. And of course, the parents involved who have the issue with borderline are going to be feeding that messaging too. It's your damn fault. You made this happen.
But it took me 20 years of clinical practice before I recognized the signs that indicated
When it's happening.
that seduction. And I think I'm okay. I don't want to say that I'm good, but I think I can recognize it now. But I couldn't for a long time. And I think I'm pretty good in clinically. And so if I couldn't, then I know that the average person can't see that until it's way too late. And you could become engaged in a long-term relationship or married to somebody like this. And how do you navigate that when the person can just flip from good self to bad self and you don't have any idea what's going on?
You have to learn about boundaries. You have to learn how to have boundaries, and whether that's as a clinician. I remember one individual that I saw who was diagnosed with borderline personality disorder, who had sexually abused some children and was required to come and see me. And when he came, I discussed with him what the boundaries were. And I said, I find that to be repugnant and repulsive behavior, and I won't support it in any way. I don't care what the justification is.
So did he dangle it out in front of you? Like, hey, I want to talk to you about how I was with these children?
Well, they always do that. They always test you. I mean, they come in, and I hesitate to say anything is always, but in this case, they always will test you. Do you have boundaries? Will you stick to your boundaries? The example I was going to make is this guy would come in and we would talk, and I said, it's okay to talk about your hungers, your desires, your fantasies, whatever, but if you're talking about behaviors and you cause me to know that a specific identifiable child is at risk, I will call the state on you right now.
While you're sitting here.
Yeah, absolutely. And he said, well, I don't like that. And I said, frankly, I don't care.
Yeah.
And he said, well, the last two psychologists that I was required to go see, they would work with me on that. And I said, well, I won't. You need to know that ahead of time. And if you don't want that, then don't come back. But if you come back, those are the rules. That's going to happen. So I saw him for a few months, and he came in, and he was all distraught. He'd been accused of something over the weekend. And I said, okay, I got to make a call. And he said, well, no, because this family called the state, and they came out and they said, no, it was a misinterpretation of reality. Nothing happened. And I said, well, I need to see a documentation of that. And he said, no, I'm not going to show it to you. I said, okay. And I went over and called the hotline. and said, here's the information that I have. And I hung up the phone, and he called me an SOB. He said, I can't believe you did that. I said, you better believe it. I will always do that. That is the boundary. And I told you that. So if you're going to come and see me, and we're going to work on these issues.
Did that actually help the therapy, or did it destroy the therapeutic rapport?
Well, I'm not sure that there was any therapy going on. We were still navigating the dance.
But did he come back?
He came back for another month or two, and then he moved on. So I don't know what happened. He found a
somebody that would play
psychologist in a residential neighborhood that practiced from their home, which I think was very dangerous, especially for seeing that type of clientele.
Yeah.
But anyway, he moved on, and I lost track of it. So
yeah, well, my wife has been adamant that no one can ever
come
know
to your
our
house.
address. Yeah.
She lets me come here.
Any of my clients. Yeah. Back when there used to be a phone book.
Yeah.
You remember phone books?
Yeah.
And you used to get your name printed in the phone book, and she would pay any amount of money that AT&T required, because you had to pay to keep your name out of the phone book, not to put your name in the phone book. She would pay any amount of money that was required for us to not be listed in the phone book. Yeah, and that's probably the right way to do it. But yeah,
a lot of people I know do it.
Yeah.
Exactly that, or did it that way when that option was available.
So I actually want to ask you a really, really important question, but let's take our break, and then when we get back, I'm going to ask you something, okay?
All right.
Hey, Brett, if you were going to tell somebody to check out something on the internet to help them with their mental health, what would you tell them?
I'd tell them to listen to Psych with Mike.
Why would you tell them that?
Because it's probably one of the most easily listenable experiences you can have that will give you information that's useful for a whole spectrum of concerns that people have.
I agree, and I have actually been told that by at least a dozen people, several of whom were not married to me, and some of them didn't even know me.
That's amazing.
It is amazing. It's when we get that kind of feedback from people, it is so incredibly humbling and overwhelming for me.
It is for both of us.
Yeah. So we really appreciate it. And as always, if it's Friday, it's Psych with Mike. Okay, we're back. And so before the break, I had said that I had a really important question for you. And to ask you this question, I'm going to lay a little bit of a context for it. I worked in a hospital for 20 years, which you know. That's where you found me and rescued me. But when I worked at the hospital, either as a psych tech or as a therapist, whenever a female patient upset a nurse, she was always borderline. So the nurses would say, "Oh, she's just like that because she's borderline." So to listen to them, any female that didn't behave exactly the way they wanted them to was borderline. But I never, ever, ever once heard any man get diagnosed as borderline, which obviously can't be true. So in your experience, because the story that you just told was of a man who came to you and was borderline, do you think that the split in the gender is 50-50? Do you think that it's skewed one way or the other?
Well, the evidence in the DSM says it's skewed one way. For diagnostic categorization, it's more women than men.
Mm-hmm.
So I think what you're
describing... But more women than men go to psychotherapy. So
right,
could it just be...
And, it's like saying... it used to be a joke in our community, our professional community, that secretaries could always tell. When people call the office, when clients would call the office, that they would be able to say, "Oh, obviously so-and-so's borderline." Or they'd say, "I have gaydar. I can tell. I just know. I can tell. I have radar for that." I don't find that to be an accurate degree of self-awareness if somebody says that. I think it requires a more clinical, professional assessment than just a flip reaction.
Well, of course, sure.
But yeah, just like depression, for so many years, many more women were diagnosed depressed and men were diagnosed as alcoholic. We now know depression is a significant factor in alcoholism, and so men are probably as depressed, and women are frequently not diagnosed as alcoholic when they should be.
Right.
So,
but do you think that women may end up getting diagnosed as borderline because of this artifact that I'm talking about, that in the hospital, if they act in a way that isn't complicit with the way that the quote authority wants them to behave, that they then get labeled as this borderline because it's an easy kind of throwaway thing?
Yeah, I think so, but that's one of the reasons why clinically I recommend people who are clinicians think in terms of the person in front of them, not in terms of the diagnosis on a piece of paper. You got to look at the behaviors that you see and try to make psychic contact with that person in a consistent framework. If you just look at the paperwork and there's a diagnosis and you start treating to what you've been taught about that diagnosis, you're not looking at that person.
Right.
So I go back to the argument that we sometimes have about the validity of the importance of diagnostic labeling.
And so then, actually, and I don't want to go down this rabbit hole too far, but
Sorry.
No. I'm saying me. I don't want to get distracted and go down this rabbit hole. But so I generally give everybody a diagnosis just so that I can put it on the paperwork that they get sent, so that if they want to submit it to their insurance company for reimbursement, they can.
Right.
But I don't really think in terms of this individual in front of me is this thing, because you taught me that you don't think of the client
hopefully
the diagnosis.
Exactly.
But this happens sometimes where a client will say, "Oh, what did you diagnose me with?"
Right.
Do you think that is beneficial information, that is required? I mean, if they ask, do you tell them?
Sometimes clinically, because you can get out the DSM and you can say, let's look at the typical symptoms, and then let's identify, just like the MMPI, when you get a personality inventory, there's been
Minnesota Multiphasic Personality Inventory.
Yes, has been normed on 10 million people. And so you as a clinician, you get the results back, and it's a true-false test they take. You get the results back, and it says, ask them about question 51. 90% of the people that answer question 51 true have this understanding or this reaction or this issue. So ask them if they do. So you get that feedback breakdown in the thing. You can't just make an automatic assumption because it'll give you a label that applies to this client sitting in front of you. So we come back to the whole thing about the relevance, usage, and acknowledgement of a diagnostic label.
So would you say then that, and again, I don't want to go too far, but would you say that is then an individualistic call? So sometimes you would have that conversation with the client, and sometimes you'd say, I don't really think that matters. I don't think of you as a diagnostic
I would
label.
have that discussion with the client. I mean, they have the right to that information, and they can demand it, and you are required to give it to them. You also clinically should have been taught that if you're going to diagnose and use a label, you use the least damaging, ethically, clinically applicable label.
Right.
So, and so clinicians tend to find a cluster of labels that they use a lot.
Yeah.
Parent-child disagreement. So then they got to using them too much. So then the DSM was revised and they took that out. You can't use it anymore. So you got to find something else. It's a game that they play for insurance coverage more than a clinically accurate messaging.
An adjustment disorder has always been in that category.
But how many clients did we both see over the last 30 years that came in that were depressed? But you had to be careful about giving that diagnosis because 15 years from now they may want to get a security clearance. And I've had people come back for FBI clearances that I saw 20 years ago saying, what'd you see? When did you see it? How did you diagnose it? What were the issues? And that was like 20 years ago. People change.
Well, and our memories may not extend,
which is
20 years. And if you only have to keep your notes, but if you only keep your notes for 7 years, and they ask you about 20 years ago, well, I don't have notes for that.
So then that's the answer you give.
Yeah,
that's what I know.
Exactly.
Right. Again.
Right. So coming back to specifically the borderline personality disorder issue or topic, do you find that there is a difference in treating males and females? Or do you think it's the same thing?
I think the challenge for either is to create the safe holding environment and for you to be consistent and well-bounded in terms of your resistance to their seduction.
Yeah, I think
so
that's
if they're going to
true.
seduce you by having a crisis and say, I can't pay my bill this month, can you cut me some slack? If you're going to flirt with that, or if they're going to come in and say, I'm suicidal, I want to call you, I'm going to write you letters. They'll write you letters because a lot of times when they go home from your session, they won't remember you. They won't believe that you're real. They won't remember what you talked about. So they'll call. What do we talk about? And they expect you to chat with them on the phone, but not bill them for it. So they'll write long letters. And one of the standard ways that I was trained to respond to that is when they come in the office and they give you the letter, they want you to read it in front of them, and then they want you to respond to it. You don't do it that way. You hand it to them and say, you have to say the words. You read it to me. Then we'll have a conversation. They hate that. They abhor that. And that's one of the triggers that says to me, this is what I'm dealing with. But that happens with men and women. The whole suicidal thing. I'm going to kill myself.
So I'm going to disclose something, and hopefully people don't judge me.
Oh, they will.
In my experience, so the few times that I know that I've dealt with this, when it becomes obvious that I'm dealing with this and it's a female, I've found that I find that to be flattering. When it's a male, I find that I don't like it.
That's interesting.
The seduction,
what
I
do you
think
think
is
that
the
says?
same. I don't know, because I find that kind of seductive behavior in men to be less appealing than I do in women. Yeah. And clearly that's me. I mean, and I don't think that I am, trying to cover my own homophobia. But I just don't find it to be an attractive quality in a man. And I try, and I think I do a good job of not allowing that to be something that comes through in the therapy, but I'm just being honest. That's how I've experienced it.
For what it's worth, I know some clients that you have seen who were gay, who did not experience you as being homophobic.
Oh, yeah. I don't think I am.
Yeah.
And so I'm saying I don't think I'm covering up any homophobia.
Yeah.
I just am very aware that of the clients that I know absolutely 100% were borderline,
right.
Some have been female, and it's been rare because I don't feel...
So the seductive artifice of the female...
I'm just saying the seductive
you are more
part
vulnerable
of it.
to that. And again, we're using the word seduction not as a sexualized term.
Yeah.
What draws you to them as a masculine male who culturates to rescuing women, taking care of the family, taking care of women, is a stronger cultural pull than the urge to rescue a male who's being fragile and displaying signs of fragility.
Right.
That doesn't work for you. So then they'll find another card to play.
Yeah. But I wonder if those individuals, if that is something that they experience in the larger population.
That's a great question to ask them, and it's a great discussion to have with them. I'm finding this getting in my way here, being able to hear you. Can we talk about it? Because again, that comes back to the healthy boundary of we can talk about anything.
And my guess is that they do experience that in the larger population.
Yes, of course. So, it all replicates itself in therapy.
And so if somebody is hearing this and they think that may explain them and their male, then
but you can't do it accusatively. You're the clinician.
Yeah.
You're inviting a discussion.
Yeah.
You're taking ownership of a reaction that you're trying to communicate. You aren't accusing them of anything.
No.
You aren't saying they're
No.
bad or it's a
No.
failing. You're saying this gets in the way.
If you have experienced this and you think that this might,
happens elsewhere.
that it isn't you.
Right.
Well, I mean, it may be you, but it isn't. It isn't a bad thing. It isn't something that you need to be ashamed of.
Yeah.
It's something that you need to think about and maybe even talk to somebody about and see if it's something that you need to address.
Yeah. Yeah. So when I was young, I had a car that had a steering wheel that would turn halfway around before the wheels would start to turn. So when I was driving that car, I had to be conscious of the fact that there was a lot of play in the steering wheel. And there were two paths forward that I understood. One was take it somewhere and get it fixed so it didn't happen. The other is when you drive the car, you have to be aware that there's a lot of play in the steering wheel. So give yourself time, be alert, don't just automatically drive. I think life is like that. We have behaviors that cause reactions in other people. So if these are pointed out to us, we have an opportunity to say, do I want to change my behavior? Am I able to change my behavior? Or do I have to understand that I come across that way and any number of people will have this reaction to me? Am I okay with that? If I'm not okay with that, what can I do about it? If I am okay with that, okay.
So, we've talked about this in terms of narcissism and the difference between Kernberg and
Masterson?
Kernberg and Kohut, and their work on narcissism. So, and the ability for the individual to be aware of their narcissism and to change.
Yeah.
And so do you think that people who suffer from borderline personality disorder, do you think that they have an ability to become aware of this and to be able to moderate or modify that behavior?
Yes. I think they have the ability to identify the triggers and the reactions or have them identified for them. And for instance, an anger outburst, get into fistfights. And they can learn how to not get into fistfights. But I don't think that piece of change by itself resolves the issue in their life. It's just one brick in the wall. And so then we pick another brick, and then we pick another brick, and we try to work together to build a wall that leads down a path to change.
So if people want to get a hold of you and they want to do therapy
I have
with
retired. I'm not available.
I knew that was your answer. And so I'm just playing with you because I know that you don't. But do you recommend anything for people who might be looking to work with somebody? Do you recommend a book that they could read?
In today's world when everything's available on Google, I think there's limited benefit to doing that kind of research for yourself. My recommendation is to find a qualified therapist at whatever their credential level may be that you can afford. Go in and visit with them and see how you feel. If you don't feel like it's a connection that will make, then move on and find somebody else. If you do feel okay, then stay for the ride. I used to say when I was in practice to people that were hesitant to come and see me that didn't really know me but had been recommended or whatever, come in and do 2 visits and I won't charge you. And if you decide to come back after 2 visits, you pay me for the 2 visits and all the other visits. And if you go away and don't come back, then okay. I'll invest that much time in getting to know you and giving you that opportunity because I believe that when you come in the room and sit down, you'll feel if I'm not right for you or if maybe there's some possibility.
So hopefully that was a positive thing for people. And as always, the music that appears in Psych with Mike is written and performed by Mr. Benjamin DeClue. Go to the internets and find us on Apple Podcasts. Leave us a comment and rate us. That is always very much appreciative. And
you can send us questions or comments, reactions to the conversations that you listen to. There's that opportunity on the YouTube page for sure.
Yeah, and we are looking to get more or back to
feedback that way.
Well, but also just back to the roots of a more clinical presentation. So if people especially have things that they are wondering about a diagnosis or about psychology in general, please send those to us, because we would love to be able to react to those. So if it's Friday, it's Psych with Mike.